Hello, welcome to schizophrenia section. So this is a topic that a lot of people find interesting, the mental illness side of things. So schizophrenia is a severe mental illness. It's classified as a psychotic disorder, and it's characterized by disruptions in thought, perception, emotion, language, sense of self, and behavior. Typically affects about 1% of the population. Um, The Diagnostic Statistical Manual 5 suggests that you need symptoms to be present for at least 6 months. Two or more of the following symptoms must be present, so either delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. So having worked with plenty of paranoid schizophrenics, I've got lots of experience working with the people who experience these kind of issues. So let's look at some of the positive symptoms. So the positive symptoms means it's in addition to normal functioning. So schizophrenics typically will have hallucinations, mainly verbal, although they can be any sense-based, visual, tactile, olfactory, and gustatory. A lot of schizophrenics have command hallucinations, so the voices are telling them to do certain things. If they don't do certain things, then maybe they'll get hurt or their family will get hurt. These can be very distressing for the patient with schizophrenia. I think it's very important to treat people with schizophrenia as human beings. They are nice. You know, most of the people I met were really nice, um, friendly, had good sense of humours, but they were just living with this terrible illness. Delusions, common delusions include, I mean, just to start off, a delusion is a kind of belief, irrational belief with um, a false belief. So common types include persecution, delusions of persecution. So people might think that people are going to hurt them or put them in jail or something. Delusions of reference, maybe delusions that objects hold personal significance, say. Delusions of grandeur, where they think they've got special abilities or special powers, like they're Jesus or something. And thought disorder, so you can get disorganized thinking, disorganized speech, loosely connected words. Um, you might come across things like word salad or derailment, where they just go off track and talk about different things. But there is a case study on YouTube of a patient called Gerald. If you look at it, you look up for it, Gerald, schizophrenia. I think it's with Dr. Bigelow. It's worth watching. It's very good. There's also a patient called Janny and with Dr. Phil. If you look at that on YouTube as well, that's quite a good one. She's a kid who's got schizophrenia and she has all these imaginary friends and imaginary pets. She calls them numbers and things. Okay, so these are the negative symptoms. So these are an absence of normal functioning. Now, you've got alogia, avolition, affective flattening, and anhedonia. Now, an easy way to remember these is that they all begin with an A. So it's like a quadruple A battery. You've got A. So alogia is speech poverty, brief, empty replies to questions. Avolition, a lack of motivation for goal-directed behavior. Difficulty beginning and sustaining activities. Affective flattening, reduced emotional expressiveness. So, you know, somebody's died and they might just be emotionally flat, just little response to it. Anhedonia, inability to experience pleasure from normal, enjoyable activities. From my experience working with schizophrenics, I'd probably say most of them probably lacked a bit of goal-directed behavior. I remember one patient would just sit in the house all day, just looking out the window. Um, didn't really engage in any activities really. Although some other patients used to go and visit were quite eager to do things, like reading and listening to music and stuff like that, and keeping busy. Especially with the voices, they can be very distressing. Okay, so in terms of issues when diagnosing and classifying, so you've got issues with reliability. How consistent are the diagnoses? So is it a consistent diagnosis between, say, psychiatrists in America and psychiatrists in the UK? There is a study that found 2% of UK psychiatrists diagnosed schizophrenia from a vignette, which is like a made-up case, compared to, I think it was 68% in America. So there does seem to be some inconsistencies in or unreliability in diagnosis. Validity. Is the DSM a valid measure of schizophrenia? Now, there was a study by Rosenhan called Being Sane in Insane Places. And these patients got admitted to hospitals in America, and they reported they were hearing three words: stomp, hollow, and thud. And they got admitted with schizophrenia, although I think some others got a slightly different diagnosis. But once they were admitted, they behaved normally, and they found it very hard to get out. I think they were in there between 7 and 52 days, and their behaviours were getting labelled things like queuing up for lunch was oral acquisitive disorder. Making notes and writing things down was pathological writing disorder. So you tend to get this labeling effect with schizophrenia or any mental illness, really. Once you're being diagnosed, you kind of get this stickiness of labels, and they found it very hard to get out. But it goes to show that maybe the DSM wasn't a valid diagnosis. And then they actually said to the hospitals, we're going to send some more patients in, and they didn't send anybody. And then they were turning people away who possibly did have it. So initially they were making like a type 1 error, false positive, and then in the second part they were turning people away who possibly did have schizophrenia. So that was a type 2 error, which was a false negative. One thing you got to think about with schizophrenia is that a lot of them have comorbidity. So they've got schizophrenia and they'll probably have anxiety and depression. A lot of the people I used to visit had at some point used substances like weed, which seems to have a negative effect. And a lot of them reported that it was after smoking weed that the schizophrenia started. However, there is quite a high genetic component to it. So maybe they were predisposed, and the weed activated the gene. Culturally and gender. Culturally, I think the research suggests that it's more African countries that people are diagnosed schizophrenia. Although in some countries they don't even recognize it as schizophrenia. They think that they're like spiritual leaders and they're getting messages from God and things, and they can pass on that information to the group. So in terms of genes, they look at family studies, twin studies, and adoption studies. Family studies. So if you've got a first-degree relative with schizophrenia, risk is about 10% compared to general population of 1%. If you're a monozygotic twin, concordance rates are between 40 and 50%, compared to a dizygotic twin between 10 to 15, which suggests that high genetic component there. And children of parents with schizophrenia raised by adopted parents without the disorder still had increased rates of schizophrenia, supporting the genetic component because the environment is different. So I think with schizophrenia there's a large genetic component to it, schizophrenic elements in the genes. Okay, neural correlates and dopamine hypothesis. So possibly structural abnormalities in the brain, enlarged ventricles is one theory, possibly resulting in less brain matter and volume. Maybe that affects parts of the brain because of the reduced grey matter. So maybe abnormalities in temporal lobes, in the hippocampus and the amygdala. The dopamine hypothesis suggests that schizophrenics have excess dopamine. That means their neurons are firing more and possibly resulting in hallucinations, delusions, etc. Then the revised dopamine hypothesis suggested that these hyperactivity in the mesolimbic pathway to explain the positive and hyperactivity in the mesocortical pathway to explain the negative symptoms. And also other neurotransmitters are possibly involved as well. So the revised dopamine hypothesis splits it up into positive and negative symptoms, whereas the original one was just saying there's a excess dopamine because they have 6 times the density of D2 and D4 receptors. Family dysfunction. So the theory for this is double bind theory, which is where the patient will be getting mixed messages, contradictory messages, and that then affects their internal construction of reality. It's a bit like the mother who says, I love you, and then they push you away with disgust. If you're living in a high expressed emotion environment, hostile, critical environment, that could be probably a major reason for a relapse in schizophrenics. So if you imagine the patient's been in a psychiatric unit, they've been released back home, and they go to a high expressed emotion family, the relapse rates are quite high. Obviously, the stress is affecting the person. Communication deviance, vague, fragmented, or confusing communication patterns in families. They contribute to thought disorders. And I found with my experiences that the schizophrenics they're very good at sort of sussing out whether someone's lying to them or not, or whether they can trust them. So it's very important to be honest with them. Cognitive theories, cognitive deficits. So patients with schizophrenia often show impairment in attention, working memory, executive function, information processing, and those deficits may underlie both positive and negative symptoms. Impaired filter theory. So this is suggesting that a breakdown in the filtering mechanism that normally screens out irrelevant things, leading to sensory overload and difficulty distinction between relevant and irrelevant information. And metacognitive deficits, difficulties in monitoring one's own thoughts, may lead to a misattribution of internal thoughts to external sources, potentially explaining hallucinations. Now, one thing is with paranoid schizophrenics is that they can make attributional errors, and sometimes they can attribute other people's behavior in a negative way. So they have biases. They make fundamental attribution errors. So it's a bit like if they saw some people talking in the corner, they might think they're talking about them when they've never even met them, but they sort of jump to the wrong conclusion based on limited evidence, and that obviously is very upsetting for them. Drug therapy with antipsychotics. The typical antipsychotics are the first generation drugs, mainly block the D2 receptors. Effective for positive, but not very good for negative. And obviously, you can get things like tardive dyskinesia, which is like involuntary movement to your face. And once you've got that, it's very hard to get rid of it, if impossible. The second generation drugs, the atypical, clozapine, risperidone, olanzapine, these affect multiple neurotransmitter systems, including dopamine and serotonin. generally more effective for negative symptoms with fewer extrapyramidal side effects. But you can get weight gain. Obviously, the side effects are less serious than these ones. Sometimes it feels like they're just symptom swapping. So antipsychotics are effective in reducing symptoms in about 70% of the patients. About 30% show limited response. That's when maybe other interventions are needed. So, for example, if schizophrenic is what they get is they get these blister packs and they have all the medications in. They have to take them every day, say. But if they're not working, some patients will go for a depot injection. Which and also you've got the problem with the patients not taking the medications, and with some of the drugs, it can be quite serious side effects. Things like clozapine, I think it is. If you don't take that for 2 days, you can end up in hospital. So sometimes they have these injections, depot injections, instead. And then obviously the hospital know that they've taken the medication. Behavioral therapy, cognitive behavioral therapy, or CBTP. So it's cognitive behavioral therapy for psychosis. Again, possibly a good treatment, but again, it's getting the patient there and getting them to stick at it. But these are the sort of process that you go through. So you'll build that relationship. That's the main thing, I think. If you've got a good relationship with the patient. Then maybe some information about schizophrenia and some of the treatment options. Identify any challenging delusions or distorted thinking, and then develop skills to manage hallucinations and reduce distress to prevent relapse. NICE guidelines recommend CBT as a adjunct medication. So normally in combination with the drug therapy, it works better. Then you've also got to think about the families, because it's quite stressful for the families if they've got a schizophrenic family member. A lot of the time, the family members will live on their own, and the family will go in and visit them with food and things like that, because the patients generally don't go out too much. They tend to be housebound a lot of the time. And they'll only go out with care workers or family members if they're going to a doctor's appointment or something. So family therapy, it's basically about aiming to improve communication, reduce the EE, expressed emotion, and help them to function better as a unit. So you might have some psychoeducation about schizophrenia because the family members might not understand it, or they might have misconceptions about what it actually is. And then in terms of the evidence, the research indicates that family therapy can significantly reduce relapse rates and hospitalization, particularly when combined with medication. So again, they try and combine the two rather than just having one. If you're in a psychiatric unit, you might use token economy. This is where you're rewarding behaviors, positive behaviors, the token that then they can exchange for something else, like watching a film or something. So you're basically trying to catch the patient doing things well and then rewarding them for it. Probably works okay in an institution, but when they get back home and there's no one there observing their behavior and rewarding them, they might not carry on with those good behaviors that they were showing in the unit. And the diathesis-stress model. So the diathesis is the biological part, the stress is in the environmental part, and the interaction between the stress and the environment. The gene and the environment can activate that gene to maybe trigger off the schizophrenia. So it could be anything like I said before, taking drugs, particularly cannabis or weed. That seemed to be a consistent pattern in the patients I saw. And then obviously stressful events, trauma, if they've suffered abuse or anything like that when they were younger. So anything like that can trigger off this gene that they're predisposed with, and the result is the schizophrenia is triggered. So the interactionist approach to schizophrenia looks at how the So it's basically a biopsychosocial model. So how the biological, the psychological, and the social factors all impact on schizophrenia. This is what they call the interactionist approach. It's a good model because it includes three different factors. So yeah, the biopsychosocial model. So we'll just get to the end there. So I hope this has been educational, and check out my other videos. We've got whiteboard videos and a bit more sort of lecture based like this. I know people like different things. And I'll see you in the next video.